Good day everyone, I am Michael, the moderator for this webinar. I welcome everyone for today's webinar, which is CMS Hospital QAPI Standards 2024. It's a great pleasure for me to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, BS, JD, RNCP, HRM, was COPIC's Director of Facilities Patient Safety and Risk Management and Operations from 2014 to 2020. In her role, Ms. Dixon provided patient safety and risk management, consulting and training to facilities, practice nurse, and staff in multiple states. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you very much, Michael, and I hope everyone can hear me clearly. As Michael mentioned, we're talking about QAPI, Quality Assessment Performance Improvement. Now, we've done this for years. This is not something new. It's just CMS has really started to tighten up the standards. And early last year, 2023, they did make some additional changes as it relates to acute hospitals. Now, there's still some waiting for acute or critical care, but they're in the process of getting that done. Well, I want to do a brief introduction on why we're here, and that's so if you're a facility, of course, you don't want to get one of these. That's when the state or accrediting organization comes out, does their survey, and they find deficiencies where you have to develop and present a plan of correction. How does it work? The regulation itself starts in the Federal Register. From then, CMS publishes it into a transmittal that just tells everybody, hey, this is out there. And then they develop guidelines and survey procedures for their surveyors. With the changes going on, you want to make sure you're keeping up. So if this is you're in compliance, this is your role, I would start with subscribing to the Federal Register. I have the links for these items, by the way, here on this page. The conditions of participation, the manual part we're talking about, first came out in '86. They split the regulation into tag numbers. That's how they would identify any deficiencies. You can see here, these are all of the items over which CMS has responsibility. And this is the topic we're talking about, QAPI. Real quick on deficiencies. I mentioned you don't ever want to get one of those deficiency reports. Another way is through hospitalinspections.org. This one is from the Association of Healthcare Journalists, and you can search it by your state, which will bring up a whole list of all your hospitals. For QAPI, there were many changes with CMS, and it was through the Hospital Improvement Rule back in 2019. Well, how it all started with QAPI initially, this hospital underwent a validation survey and part of the Hospital Improvement Rule. Now, the formal name is very long. I've got it here, the regulatory provision to promote program efficiency, transparency, and burden reduction. The overall benefits were they were trying to reduce burdens to the providers and improve quality of care. So overall, for quality and QAPI, you have to look at the quality of what you provide, the services for hospital-acquired conditions in particular, and they have the list here. I've got the link there. You know, with the links, you will have to copy paste into your search engine. I couldn't get them to automatically connect through the slides. Talked about system-wide QAPI. Now, they didn't specifically mention critical access hospitals because they're called unified integrated for multi-hospital systems. And the interpretive guidelines, the rule itself didn't include them. Those didn't come out until March of last year. All right, let's go ahead and start. We're going to be looking at acute hospital. That's primarily. Why do they want to do it? Why is QAPI so important? Well, for starters, it's the third most frequently cited of all of the 24 conditions. So the key points here, these are the key points. Develop and put into place actions that we want to improve our outcomes and prevent errors. That's really the touchstone for QAPI. Now, I put the new guidelines in here. There are certain expectations of the program. They expect you to continually study and improve your processes and service delivery. Other expectations, everybody gets to play along, all location services and departments. Under contracted services, this is in tag 83, it's in the governing body section of the manual. Oh, protected records. This one just came up recently. So in a nutshell, this memo, it outlined the privileges and the confidential status on those materials. So overall, you have to show, of course, that you have demonstrated evidence of your program, including effectiveness. The program has to include continuous collection and analysis of the data. In analysis, you should be able to show your indicators that you used. Your governing body, they have to set out the frequency and how much detail they want collected. And the descriptive information. There has to be enough information so they know what to approve. Now this is from your QAPI staff. Now this is new. The list of your indicators that you're currently tracking has to include that you're tracking your adverse events. They'll make sure that the hospital, again, through the governing body, is using that data to look at other opportunities for improvement. Just some questions when you're looking at your scope and your program. Stroke, venous thromboembolism, surgical care improvement. There's outpatient quality measures that you can also access and tap into just to get a start. Other examples, medication use. Take into account medication reconciliation. That's something your hospital probably does multiple times a day. As far as your activities, use the data to identify those opportunities. The guidelines call upon the hospitals to look at their program data to make sure you are establishing those priority areas. Again, they said, look at your high-risk areas. Maybe you also have an immunocompromised patient areas. Problem-prone areas, handoff communications could be another one. How often does it occur? How widespread? The surveyor is going to ask for a list of your current activities. Now, these guidelines are very long. They're new and it's very long. I've hit on some of the key areas here. Now, CMS in their definition, they adopted from the Quality Interagency Coordination Task Force back in 2003. Didn't change it. Maybe it's an infection control or sterile processing. Then they define a near miss. Now, from a patient safety, it's considered an error. Just keep that in mind. After you do your analysis that you identified the cause, then you got to take action. If you are going for certification, surveyors will ask for evidence of your reporting system. They want evidence that the staff has been educated and training. You do have to conduct your projects. The number and scope, that's up to you. The QIOs, or Quality Improvement Organizations, you can participate in one of comparable effort. Their job in the new guidelines, they gave us some definitions as opposed to a project versus an activity. Be able to show what projects and the activities you have. What do they entail? They want a list of your distinct projects that you're currently doing and those you did within the last 3 years. The board has to make sure the program reflects the complexity. Again, executive, they have full responsibility and authority. Leadership is responsible and accountable for this program. The responsibilities, you have to make sure standard requirements are met. Leadership is also responsible to make sure that there's communication on safety that is done hospital-wide. The governing body must make sure that those services are done safely and effectively, and they're included in your program. Other evidence, budget, that there's resources for the program. Otherwise, we have to have adequate resources to do our job. All right, briefly on unified integrated. If you have 2 or more hospitals under one governing body, you can have a shared program. You have to have policy and procedures that make sure each hospital or location are given consideration. All right, as we start to wind down, I do want to just go over critical access hospitals. Again, there were changes in 2019, the burden reduction memo, the board, and I'm going to say board collectively here because it could be an actual body, a couple people, or one. Criticals can have one designated individual acting as the governing body. Measures have to focus on those to improve outcomes. All right, QAPI and event reporting. Again, you are required to track your events. And we know through several reports, nurses and others, they just don't report them. They don't think it's an issue. IHI has trigger tools. They help identify errors. There's a global trigger tool. And while we're waiting, I'll also just show you some of the information in the appendix. National Quality Forum, great resource. Thank you, everyone, and thank you to Michael.
Thank you everyone for participating. You may all disconnect now. Have a great day ahead. Bye-bye.